Hi, welcome to this video where we're going to be considering the physiology of the oocyte maturation as well as the pathophysiology behind polycystic ovarian syndrome. So to understand PCOS, which is polycystic ovarian syndrome, first we will need to understand how the oocyte matures, and specifically I'm approaching this from the onset of hormonal interventions or hormonal control of the oocyte. The questions we should be able to answer by the end of this video is what hormones act on the follicle of the ovary, what hormones does the corpus luteum release, is there a particular hormonal imbalance besides FSH and LH in PCOS, and why are there cystic follicles in PCOS? So to understand this, you need to know about the different cells of the follicle. So what is a follicle? The follicle is the functional unit of the ovary. Okay, this is a follicle right here, and the follicle contains the oocyte, which we need to mature into an egg. And here are the theca cells, over here on the periphery. Here are the granulosa cells. They are surrounding this region here. These are the granulosa cells. So, so what's happening is that we are trying, this whole follicle is responsible for allowing the matured egg to be released. So we're trying to maturing of the oocyte into an ovum, into an egg. So it's kind of like maturing a child into an adult. It requires two parents who are both very motivated. So the parents here are the granulosa cells and the theca cells. So the theca cells and the granulosa cells are basically responsible for helping. They are the supportive cells. They are the supportive cells of this follicle that, under the action of certain hormones, allow for this oocyte to mature. So here's the anterior pituitary. The anterior pituitary releases two hormones like luteinizing hormone and FSH. Luteinizing hormone, what it does is it comes and acts on the theca cell. Excuse me. So it acts on the theca cell and it allows the theca cell to release androgens. These androgens will then go over to your granulosa cells, and here the androgens are going to be converted into estrogen. So these are the two important pathways that help for the maturation of the ovum. The theca cells were acted on by luteinizing hormone. The anterior pituitary gland released luteinizing hormone and FSH. The luteinizing hormone goes and acts on the theca cells to release androgens. These androgens then go over to the granulosa cells where they're converted into estrogen under the action of FSH. So then your FSH goes and acts on your granulosa cells, and these granulosa cells convert your androgens into estrogen. And then that estrogen goes and acts to mature your oocyte into an ovum, right? So that estrogen goes and acts on your oocyte to be matured into an ovum. So let me explain the same process here on a histological picture. Here's your oocyte. Here is your zona granulosa. These are your granulosa cells. And here are your theca cells. Here. So again, what's happening? Your anterior pituitary releases two hormones, LH and FSH. LH goes and acts on your theca cell, and it causes the theca cells to release more androgens. So the theca cell releases androgens. Then these androgens go to your granulosa cells, and here these androgens get converted into estrogen. But the driving force for the theca cells to start to produce the androgen, the luteinizing hormone. So if this is your oocyte, here are your granulosa cells, here are your theca cells. The theca cells get acted on by luteinizing hormone to produce A for androgens. These androgens go over to the granulosa cells where the androgens get converted into estrogen, but this is under the action of FSH. So your two main important guys are LH and FSH. And LH acts on your theca cells to produce androgens. These androgens must be converted into estrogen somewhere, so they go over to the granulosa, which easily converts them into estrogen, but remember it's under the action of the second hormone, FSH. That estrogen will then cause the oocyte to mature. And as the oocyte matures, it can become a mature ovum. So the oocyte matures because of the estrogen. Once the oocyte matures into a mature ovum and it's expelled, we are left with something called the corpus luteum. Just a quick one, if you can't remember which cells of the ovary are acted on by which hormone, just remember timeline for my girlfriend's ovaries. So TLGF. It's kind of sad. So T is for the theca cells are acted on by luteinizing hormone, and G for the granulosa cells are acted on by the FSH. So, okay, we know that the oocyte gets released into a mature ovum, and what's left of the residual follicle, which were all of those supporting parts, is now known as the corpus luteum. Corpus means body, luteum means yolk or egg yolk. So I want you to think of the corpus luteum like an egg yolk that has suddenly got the control in his hand. This is him holding a steering wheel. He's controlling everything. He is the master player. The corpus luteum is a vital yet temporary organ that plays a crucial role in fertility. It is an endocrine structure in females that only exists within the ovary once the ovarian follicle has released a mature ovum during the ovulation. It's dynamic. It's not always there. And it's within the ovary. And what it does is it helps to kind of sustain because there's an LH surge that leads to ovulation. The LH surge helps the oocyte get expelled. Okay, so it helps the oocyte get expelled outwards. And after that, we're left with the corpus luteum. The corpus luteum mainly produces progesterone. What happens to the kind of follicles that become degenerated? They become large and cystic. So especially if they're not under the action of any hormone, they become large and cystic. Also, one more thing, the estrogen was responsible for maturing this oocyte. The other thing estrogen does at the same time it's maturing this oocyte, it also puts the uterus into a proliferative phase, which is getting the uterus lining ready for the egg. Now, to understand polycystic ovarian disease, you need to know that in polycystic ovarian disease, you have excess luteinizing hormone. What does L act on? The theca cells. And due to excess luteinizing hormone, this is the entire crux of the disease. Eventually, you'll get reduced FSH. Now, Reduced FSH is going to lead to symptoms and clinical features like infertility. There will also be amenorrhea in these patients. And because of the excess androgens, which I'll explain, they'll also have hirsutism. So how can an elevated luteinizing hormone cause such a disease in which the ovaries become the follicles become enlarged and cystic? This is the whole ovary. In it were the follicles, which were the functional units, and these become enlarged and filled with fluid. How? Well, luteinizing hormone rises. Let's talk about the pathophysiology. So, luteinizing hormone rises, and as luteinizing hormone rises, it will start to produce more and more androgens inside the theca cell. These androgens will not only go over to the granulosa cells to be converted into estrogen, but they'll also go into the bloodstream. And as more and more androgens in the blood accumulate, this will cause male pattern hair growth. This will cause hirsutism. Also, the androgens are going into the granulosa cell to be converted into estrogen. Fine. But there's too much luteinizing hormone, don't forget, meaning that there's a lot of androgens going into the granulosa cell, which are overburdening the granulosa cell. The only outcome will be excess estrogen. Estrogen was actually supposed to, the more estrogen you have, the more FSH will be inhibited because of negative feedback. So as FSH gets inhibited, we will have a lot of reduced FSH. In the end, we will have an LH to FSH ratio of 1 to 2. Here's another diagram which will explain this all over again, just to make sure you've understood it. Your luteinizing hormone levels rise, and they go and act on the theca cell. This results in the theca cell producing more and more testosterone or androgens. The testosterone can go into the granulosa cell to be converted into estradiol, which will then negatively inhibit the FSH. But the testosterone can also go into the bloodstream, and as testosterone accumulates in the bloodstream, two things can happen. One, hirsutism, because of testosterone is kind of like an androgenic male, so I wouldn't call it male, but androgenic hormone. Two, testosterone, when you have excess of it, it can be converted into estrogen too. So the other thing was that testosterone went to the granulosa cell where FSH was driving the conversion of that testosterone into estradiol, into estrogen and estradiol. What does estradiol do? It goes into the blood. It, goes to cause the proliferative phase of the uterus, proliferation of the uterus. The other thing estradiol and estrogen causes, it can deposit into the adipocytes, causing fatty deposition, leading to obesity. And because of this entire pathway, excess androgens, because of this excess luteinizing hormone, you will get a lot of these precursors, these molecules, and a lot less FSH. We address this, we address this, we address this. Okay, besides FSH and LH, yes, you also can get hyperinsulinemia in these patients because they are obese. These patients with PCOS are obese. These patients with PCOS are often obese. This hyperinsulinemia, they develop resistance to insulin, which will eventually make them put them into type 2 diabetes. All of the clinical features of PCOS, these patients develop ovarian cysts, which look like this. This is a normal ovary with the normal follicle with a normal oocyte developing egg. However, in PCOS, what do you have? You have these enlarged cystic follicles that are disrupting the structure of the ovary. What else do we have? We have hyperandrogenism, which is male pattern hair growth on the chin, on the upper lip, around here. There's also hyperinsulinemia, there's ovarian cysts, obesity, and endocrine dysfunction. How would I draw this lady? So she's got male pattern hair growth and acne, because testosterone can also cause acne. Male pattern hair growth. And actually, they might have hair loss on the head. They're also obese. They have amenorrhea, abnormal and lack of menstruation. They have infertility. Why are there cystic follicles in PCOS? Because there's one important thing that I didn't mention. Why are there cystic follicles? Because when you don't have FSH, when you don't have FSH, you're going to have a lot less impact of the granulosa cells. Lack of FSH is going to lead to these granulosa cells to degenerate. These granulosa cells will degenerate because you have lack of FSH. Lack of FSH is going to lead to degenerated granulosa cells, because obviously use it or lose it, right? Degenerated granulosa cells are then going to become cystic and enlarged. Cystic and enlarged. And that is the exact pathogenesis of, because there's less FSH, so the granulosa cells will not work that well and they will be degenerated. Thank you for watching.